And you're discussing with me, Sebastian, is that right?
I think we have two discussants actually.
Oh, let me see if
Uh, Valeria mentioned it was. Let's see who it was.
I think she just said Sebastian is discussing today. Yusuf is presenting, Sana is scribing, Kritika is doing.
Okay.
All right. Are we ready? I think so. We're recording. All right. Good morning, good afternoon, good evening, everyone. Welcome back for another Neurology Virtual Morning Report. Glad to see everyone. We have my colleague at UCLA, Sebastian, is going to be discussing a case, and I think Zachariah, sorry, you're going to be presenting. I think Valeria said Yusuf is presenting, but did you guys swap or maybe mistake?
Hi, good morning, good afternoon, everyone. Um, Yusuf was initially supposed to present, but shame he's quite ill.
Oh,
But I had a nice neurology case that I thought
perfect.
we could all.
Thanks for filling in at the last moment. Appreciate it. Um, all right. Do you want to tell us, Zachariah, just the chief concern?
So the chief concern is acute psychiatric disturbance and tremor, and I'll stop there.
Okay. Acute psychiatric disturbance and tremor. So, what's coming to mind, Sebastian?
Well, a few things jump straight to mind. I think there's anything the timing wise, thinking of tempo, something that acute. My first thought is this intoxication. The patient who's again been acutely psychiatric altered, is he hallucinating? This tremor, is this going to be a sort of PCP, ataxic nystagmus, type pattern? So, acute intoxication definitely comes to mind. I guess acute infection comes to mind. Again, thinking about that tempo, something quick. Is this some sort of rhombencephalitis, affecting the cerebellum, maybe causing this sort of tremor? Is this, and really infectious wise, probably viral or bacterial? Okay, but again, we'll hear what the tempo of it is. I think sort of vascular is possible here. I've seen certainly sort of vasculitic cases present, acutely. Is there a small, infarct in the basal ganglia producing this sort of tremor? Superimposed maybe with psychiatric illness in the setting of, diffuse embolic sort of showering. So lots of things on the table there. And then, of course, again, depending on the history, if this is leaning more towards something on the late subacute, and then, of course, any of the autoimmune encephalitis coming to mind. I think that's really, the kind of the probably the first thing that came into most people's mind when they heard the history. And we'd love to hear a little bit more about again the tempo exactly, whether the patient has any previous medical history, and what else we see with the chief complaint. What other symptoms we've got in there, and whether there's any comorbid or prior psychiatric history. So that's where I'm at. I'll add in there paraneoplastic syndromes, again, sort of bucketed with a autoimmune picture. And then what else am I missing? Yeah, that's what's coming to mind right now. But I'd love to hear more in the history to pass out those early differentials.
Sure, great thoughts, Sebastian. Yeah, I agree with you. Just you mentioned a lot of possibilities here. Just in your experience, um, what do you think is if this were not morning report and this were the real world, and you heard of acute change in mental status, acute psychiatric disturbance, tremor? What sort of broad bucket would you be thinking outside the morning report context?
Oh, alcohol, withdrawal, I think would be my number one. I mentioned intoxication at the beginning, but forgot probably the most common would be alcohol, definitely that delirium tremens phase, that sort of 24, 48-hour withdrawal mark. So, obviously that's, again, outside of the virtual morning report bubble, but certainly in the real world, that's one thing I'd mention. And other sorts of drug withdrawal, I think would be in there too.
Perfect. Yeah, I agree with you. Sort of medical causes overall. Yeah. So just to talk about acute psychiatric disturbance is a little bit stated a little bit more different, a little specifically differently than saying just acute altered mental status, where we think of confusion. Here we're probably going to hear more about psychosis, agitation, behavioral changes, as opposed to sort of acute confusion, which can also have behavioral changes. And obviously, whether we're talking about the mind or the brain, it's an artificial barrier that we've created here, and these are the same organ. And so whether we're talking about acute psychiatric disturbance or acute change in mental status, I think we can kind of have a similar framework. I know people like to use the MIST framework here. As people have heard me say many times, I'm not a big fan of mnemonics in general because I just find it's hard to remember what things stand for, especially so many words begin with I in medicine: immunologic, infectious, iatrogenic, idiopathic, etc. And I like to think in terms of time course, as Sebastian did. Um, and because there are some elements on the MIST in the MIST framework that would not be relevant if it was chronic, would be more relevant if it was acute, etc. So to stick it to the time course. And so I actually have a very simple framework for acute alteration in mental status, which is just medical, neurologic, psychiatric. Those are the three broad buckets. And as Sebastian said, and I agree, in the real world, we're not in morning report, reading a CPC, etc. An acute change in mental status is probably going to be most of the time something medical. Neurology is always involved. Could this be stroke? Could this be seizure or postictal state from unwitnessed seizure? Could this be encephalitis? Could this be meningitis? The acute sort of can't miss neurologic diagnoses. We have to think about them. And sometimes when we're not sure, we have to work them up. Or sometimes we're pretty sure it's not any of those and it's something medical, and we still work them up because it would be devastating to miss any of these for the patient. But in general, most of these boil down to some toxic metabolic disturbance, whether that's a systemic infection, a medication side effect, a drug intoxication, drug withdrawal, acute renal failure, acute liver failure, etc. Even as people get older, even a simple UTI, pneumonia, viral URI, older patients, particularly if they have pre-existing dementia, can get quite confused, delirious in that context. And neurologic and psychiatric, if the patient has a prior psychiatric history, they could still have a new medical or neurologic problem, but one would probably elevate in the differential diagnosis some acute manifestation of the patient's ongoing psychiatric condition if they ran out of their medications or weren't able to take their medications or had a GI illness and were vomiting their medications and had a psychiatric decompensation. And then the neurologic conditions that could cause an acute, and if we mean acute here, as Sebastian said, was sort of parsing it to, is this really acute hours, days, or is this more kind of days, weeks time frame? If it's really acute, sudden, could this be a stroke with a psychiatric disturbance and tremor? That's a little bit of a stretch. Could the tremulousness be seizure activity? And the psychiatric disturbance be ongoing non-convulsive seizures? Possible. If this is more days, we're in the sort of more meningitis, encephalitis bucket. And then if this is sort of days, weeks, getting into the more subacute, then of course, as Sebastian said, we think about autoimmune conditions. And if this is a young person, particularly a young woman, we might wonder about something like anti-NMDA receptor encephalitis. So that's the altered mental status piece here. So medical, neurologic, psychiatric, most of the time going to be medical. Patient's going to get a medical workup, and most of the time, if this is very acute in onset, patient's going to get worked up at least with some head imaging of some type, CT, maybe even CTA, maybe even MRI, to make sure we're not missing stroke or HSV encephalitis or something like this, if this is really either sudden or in the hours to days end of the spectrum. So that's the altered mental status piece. Psychiatric, as I was saying, a little bit more specific than saying altered mental status, but I think kind of in the same frame of differential diagnoses. It localizes to the brain, right? And it's sort of, whether it's mental status or behavior, we're sort of talking about the same differential diagnoses. And what about the tremor piece, Sebastian? Feel free to take it separately, how you think about that, or feel free to put them together.
I think it to me, I can create a separate bucket really, and the Venn diagram overlaps slightly, but of course the tremor, got a very, very big differential. Again, really passed out by tempo, and of course, I think like 95% of the causes of tremor, in the outpatient setting will be chronic causes. But again, we don't have an age for the patient that will, kind of structure it. But I don't have a specific approach to tremor per se, other than just describing, the qualities of the tremor and using that to help determine what the underlying cause might be, looking at the amplitude, frequency, parts affected, and so on. So that's where my history will be helpful, but also my exam. And I think that would be my main approach to parting it up.
Perfect. Yeah. So let's take the tremor by itself, just something we haven't talked about in a while here, movement disorders. So in the movement disorders area of neurology, we think less about localization and more about phenomenology. In the other VMRs we've had, whether it's a visual disturbance, motor, sensory, ataxia, etc., we're trying to figure out where in the nervous system is this brain stem, cerebellum, spinal cord, nerve roots, nerves, neuromuscular junction, muscle. With movement disorders, there are a few that localize specifically, classically on the boards, right? Hemibolismus, subthalamic nucleus, very, very rare in real life. I've had a friend show me one case, but I don't know if you've seen a case, Sebastian. Pretty rare to just get that subthalamic nucleus and not get the internal capsule next door and just be hemiparetic, and then maybe there would have been bolismus, but there's not. That's very uncommon. Otherwise, these don't really localize that well, but the key is really using your exam, as Sebastian said, and saying, well, is this actually tremor? Or is it stacked myoclonus? Or is it dystonia? And when the patient moves against the grain sort of the dystonic movement, there can be some tremulousness there or a tremor. Is this actually ataxia, which can cause a tremor, but sort of has a different differential diagnosis? So the first step is really observing the movement and trying to say what it is. And there is tremor and chorea and dystonia and tic and myoclonus and a whole series of hyperkinetic movement disorders. And the buckets I have for those are, if you see a movement disorder, once you know which one it is, they each have a differential diagnosis, but it falls into four broad categories, which are primary neurologic disease, something like Parkinson's disease, essential tremor for tremor, a structural lesion in the nervous system causing a movement disorder, usually related to the basal ganglia. Some systemic condition, like hyperthyroidism for tremor, I won't call it a systemic condition, a systemic state, pregnancy for chorea gravidarum, for example, and then medications and drugs. So the broad buckets for movement disorder differential are a structural lesion, a primary neurologic disease, a systemic condition, or some type of medication drug. And each movement disorder has its own differential diagnosis in those four buckets of where in the nervous system or which central nervous system disease or which medications can cause that particular movement disorder, medications or drugs, or which systemic conditions, and there's some overlap. So tremor, for example, systemic conditions, things like hyperthyroidism, anxiety, almost any medication can cause tremor, but particularly anti-seizure medications, antidepressants are on the list, are the ones that come to mind. Neurologic diseases that cause tremor, Parkinson's disease, essential tremor, a structural lesion causing a tremor. I guess we could sort of cheat and say a cerebellar lesion causing cerebellar ataxia, which is a type of tremor, or a rubral tremor, very rare lesion in the red nucleus in the midbrain, also called cerebellar outflow tremor. And as Sebastian said, when we look at the tremor on the exam, we'll want to know which part or parts of the body, unilateral, bilateral, upper extremities, lower extremities, any involvement of the head or voice. We'll want to know the amplitude and frequency, and we characterize these tremors as, for example, high amplitude, high frequency, or low amplitude, low frequency, or like the sort of physiologic tremor or enhanced physiologic tremor you might see even in yourself if you're a little hypoglycemic, a little hypercaffeinated, and you have a little bit of tremulousness. That's a very fine, low amplitude, high frequency tremor, for example. And then the state in which the tremor emerges. Is it at rest? Is it with posture, sustained posture? Is it with action? And with inaction, is it just with action, like essential tremor that's constant throughout the range of movement? Or is it an intention tremor, like cerebellar tremor, where the closer you get to the target, the worse the movement becomes? So that's tremor within movement disorders. That's altered mental status. Altered mental status plus tremor. Sebastian, you said, in the real world, right, we'd be thinking of drug intoxication or withdrawal. Anything else that you'd be thinking of? And then we'll finally let Zachariah tell us a few more than these first four words.
Yeah, again, I think the overlap there. I think I'd never rule out a structural lesion. You mentioned that you've never seen a sort of stroke per se affecting. I actually did have a case of hemibolismus from stroke. There was a tiny pinpoint. This patient had multiple cardioembolic strokes, and anyway, so that's in the.
You've seen one.
Again, yeah, I have seen one, but it's obviously, as you mentioned, very rare.
Yeah.
Yeah, I think the overlap here, I'm leaning more towards something that's either infectious or, in that toxic metabolic category, including medications and toxins and other general medical causes.
Yeah. Any particular infection you have in mind that would cause acute psychiatric disturbance and tremor?
I mean, just hearing the psychiatric description rather than just the description of altered mental status in general makes me think more towards an infectious agent targeting the limbic system. So maybe the sort of HSV family, at this point. But yeah, I think really any, I guess, meningitic, process, well, I mean, if it's something that's diffuse enough, again, may well present with confusion or altered mental status that we're interpreting as an acute psychiatric disturbance. And the tremor could be really anything. So nothing else in mind other than maybe herpes viruses if we're invoking true like limbic disease.
Yeah. Very good. Yeah. For altered mental status, acute could be meningitis, could be encephalitis, broad infectious differential. I wouldn't really think of tremulousness or tremor in HSV. Encephalitis can cause seizure, and then again, tremor. Part of the
Yeah.
differential diagnosis for movement disorder is that it really a tremor? Is it a seizure? Fasciculations? But the arboviruses, so herpes viruses, as you said, are limbic, meaning sort of medial temporal lobe, insula, inferior frontal lobe. But the arboviruses, for whatever reason, have a tropism for the deep gray matter, the basal ganglia. So, not that common to see West Nile virus or some of the other arboviruses, the viruses transmitted by arthropods, mostly mosquitoes or ticks. But I have one memorable case. Was it Eastern equine or West Nile, where the patient had sort of Parkinsonism and tremor in addition to the encephalitis, and it was a viral encephalitis with you could see on the neuroimaging basal ganglia involvement. So that's probably what I would think of with infection and tremor. I can't think of too many other unless there's cerebellar infection. Mumps can get the cerebellum. Powassan virus transmitted by ticks. I think mostly in the northeast U.S. can cause cerebellar involvement. I think someone can check me on that. And then the tremor might be ataxia, right, or ataxic tremor. Then you mentioned earlier, yeah, in the morning report context, you hear new psychiatry, new tremor, new movement disorder, and we're looking for a sort of sensational diagnosis. You might first start thinking of anti-NMDA receptor encephalitis. This is not uncommon. I've seen it more commonly than subthalamic nucleus stroke, but still pretty uncommon, probably in a tertiary center, getting, a small handful of cases a year. But that's certainly something we think about depending on the context, time course, and you can get, I think, any movement disorder with NMDA encephalitis. The classic, do you know, Sebastian, the classic movement disorder you get? It's usually when people start figuring out this isn't just new schizophrenia. Um, yeah, okay, if you don't know. Yeah.
Mm.
Have you seen a case? Have you had your own NMDA case?
One that she was treated. She was one that relapsed and was on rituximab, so
I
I
see.
didn't see
You
her at
didn't
the
see the
beginning.
beginning.
Yeah, yeah.
Yeah. Usually it's orofacial dyskinesias, which kind of looks like tardive dyskinesia, but they haven't, had a long enough drug exposure to get tardive dyskinesia. And they can have, I think, someone can check me on this. I think they can have chorea as well. Um, but probably a tremor is fair game. And the other thing I've never seen in real life, but if there's a young person with new neurology slash psychiatry and new movement disorder, one could wonder about Wilson's disease. Still waiting for my first case
Sure.
of Wilson's disease. They get classically this sort of wing beating tremor, where it's a more proximal tremor, although um, someone told me recently that that's sort of classically described and actually not the most common tremor in Wilson's. If you see a case of Wilson's, let me know. I will travel to see it, and it's on my neuro bucket list of conditions to someday see and be able to recognize. Okay, great. Well, we have a broad playing field here. Zachariah, do you want to tell us a little bit more about the history now?
Sure, sure, sure. So it is a very interesting case. I was actually consulted by the primary care provider who said that he had this 20-year-old male, previously well, no past medical history on any records. He was in his usual state of health and presented to him with a 1 to 2 week history of confusion, strange behavior, which he described as patient talking to himself, not sleeping well. And he also noted a tremor in his right hand and arm, which I'll show a video of later. In terms of review of system, no real weakness, no bulbar symptoms. Um, Patient also reported some intermittent right upper quadrant pain. but the provider didn't think anything of it. And no other positive review of systems, no fevers, no rashes, nothing of the like. And like I said, no past medical history, no past psychiatric history. Patient was not on any medications, no family history of any conditions. Socially, the patient was a student, no reported drug use, or any kind of substance use, and no allergies. In terms of the vital, I'll just do a brief overview of vital signs. Vital signs were all within the normal limits. The patient appeared quite thin and tall, and systemic exam was, for the most part, unremarkable, except for the fact that the patient had some what we noted as mild hepatomegaly. The liver was palpated about 2 centimeters below the costal margin, and the neurological exam was the tremor, and I'm going to pull up the video now. But essentially, cranial nerve exam was normal. Power was 5 out of 5 in all the limbs. Reflexes were normal, normal tone. GCS was 14 out of 15, losing the point because he was orientated to person, but not place and time, really. And in terms of a mental state, he was sort of agitated, fairly kempt with normal psychomotor activity, but at times he was noted to display some odd behavior, looked like he was talking to himself, um, fairly normal thought form and content, and of note, had a very low mood. And I'll pull up the video of the tremor now. And unfortunately, I didn't get permission from the patient to share his specific video. So the video I have was obtained from an open source online. And I'll share it now in a second.
While he's pulling that up, what are you thinking here, Sebastian?
We've got lots of useful information. I think the age is really pulling me in a certain direction. I think the total lack of other known, medical history. I mean, I think the lack of good history for alcohol or, intoxication or other known medical issues has ruled a few things out. The age definitely making me think more of something that's maybe even congenital. Is this a late, pediatric condition that's, or is this as you mentioned, sort of Wilson's rather congenital? And then again, infections are up there for me. Those are my early thoughts. And I think again when we talk about infection, it's going to be something a bit atypical given the time course. This isn't a kind of classic acute bacterial, or maybe even viral syndrome.
Yeah, great. And then when we just heard 20-year-old new psychiatric symptoms, probably wouldn't be thinking of anything neurologic
No,
yet. And then you hear about the tremor and then the liver. Um,
exactly. So that definitely you mentioned sort of Wilson's that that's definitely coming to mind. But again, I'm trying to think all the way back to to USMLE and the inborn errors of metabolism, for example. A lot of those cause hepatosplenomegaly and can cause odd behavior. I'm trying to think if there's a sort of I'm thinking here. Not this isn't going to be Niemann-Pick disease, probably too old, but in that sort of general bucket, sort of coming to mind.
yeah, great. Liver, brain diseases. Yeah, I gotta stretch my imagination here too beyond Wilson's. Yeah, it'll be helpful to if we can. Did the Zachariah, did the video not work, or do you can describe the neurology to us if that's the case, no problem. Yeah, I think in these cases, yeah, it'll be hard for Sebastian and myself as neurologists to generate a broad differential for hepatosplenomegaly, right? We'll need a help of our colleagues, but to at least look at the neurology and make sure we understand that this is a unilateral tremor. Does this look like a Parkinsonian tremor? Does this look like a rubral tremor? Does this look like um, oops, Zachariah,
Mm.
I think got bumped off.
Oh,
Does this look like myoclonus? Does this look like
yeah,
dystonia? To know what the neurology is, and then once we have a differential for that, we can cross-check it with what affects the liver. Yeah, I've never
yeah.
seen Niemann-Pick. I don't remember what the
That,
neurology of that is.
I'm wondering what something else come to mind is that neurocantocytosis. It's a patient who's got, again, sort of, I think they get a lot of hematologic issues that are associated with enlargement of the spleen or liver.
Yeah,
That again are associated with sort of movement disorders. I don't know if he's the right age to present for it.
Have you
that
seen
comes
that
to mind.
condition? Korea? No, I haven't seen that one either. Yeah, and that I think would be Korea.
Yeah,
Again, we'll see what the movement is. But yeah,
yeah,
neuro and liver. Yeah, I guess
yeah.
coming back to your initial hypothesis, did he? He has no known drug history, but is there a drug or a toxin that's been introduced that's caused both
Mm,
hepatic failure and some neurology as a result of
right.
hepatic encephalopathy? But okay, um,
Okay, I can see it. Can you see it?
yeah, I can see it. Yeah, what do we see here, Sebastian?
So just for
So,
clarification, the patient only exhibited this tremor, this movement in his right side, not the left. So it was
Okay.
unilateral.
okay, thank you. So we can, describe what body parts it's affecting. Looks like you see upper limb is clearly affected. It looks like the lower limb is
Hmm.
too. It's definitely hyperkinetic. There's no doubt about that. Um, and I'm guessing, we describe tremor, we think of something really rhythmic. It's a bit, it's almost kind of exaggerated and continuous, almost on that choroathetoid spectrum. Actually, when I look at this, I don't know what you say, but it's not got that. It's definitely hyperkinetic, but it's very almost sort of restless and agitated. And I could describe it as a tremor. If we're doing that with very high amplitude and its coarse, the frequency because of the amplitude is probably on the lower side. The my video is sort of stopping and starting a little bit, but that's what I see, and that makes me think of a tremor that's really high amplitude like that. You're thinking you mentioned it already, sort of rubral tremor can be really exaggerated, localizing to the red nucleus and the midbrain. Again, I'm struggling to put that together with a liver injury, but or of course cerebellar, uh, sort of ataxia. But it's just got that element to me of something that's almost like athetotic and restless or coriform. That's a really continuous like movement that's buried in there. To me, it's a slightly mixed movement disorder from what I can see.
Yeah. Do you want to keep cycling the video, Zachary, if you don't mind, so people I know it's just a short clip? Yeah, I see what is making this challenging. I would see if you can, Sebastian, though it's hard. Ignore the upper extremities and see how you would describe the lower extremities here. Even cover it with your hand, maybe, so you're not distracted, because the upper
Yeah, yeah,
extremities
yeah.
are a little confusing. I think I see why you're.
Mm-hmm.
What would you say of the legs?
Yeah, I mean, there's almost like an akathisia. It's very restless, uh, but it is shaking, certainly in the knees and the ankle. I guess that would look more like a sort of tremor in the legs.
Yeah, and if you just
Yeah.
looked at the legs, what type of tremor would you call that in terms of amplitude, frequency, rest, posture, action?
So I lost it, but it seems like it's there at rest.
Yeah. Do you want to keep playing the video,
And
Zachary? Sorry, you
also,
have to keep pressing.
yeah, thank you. Yeah, it looks like it's there at rest, and we know it's also postural because of the upper extremities. But so again, sort of present in um, multiple across multiple movement types.
Yeah.
It seems like moderate frequency. The amplitude, I mean, it's very very high, certainly in the arms, but it seems obviously pretty high in the legs.
Yeah, so I think the legs. So, what is tremor define? How is it defined by the movement disorders? Kind of, the official definition is involuntary rhythmic oscillation. And the hands, I agree, it's a complicated movement disorder. So we'll try if you can try to just look at his what's happening with his knees here. He changes position a few times, but once he established rest, there is a rest tremor there that is sort of lower frequency, lower amplitude, and almost looks sort of in the Parkinson's. We're used to seeing that in the upper extremities, but it has that kind of just, slow, rhythmic, and that looks more obviously one like tremor. We can see it's a rest tremor. The upper extremities, I know, Zachary, I can't share the exact patient, and this is a sort of extreme example. I don't think it's chorea in the sense that it is a continuous oscillation, and chorea, I like to say, is sort of the atrial fibrillation of movement disorders. It's irregularly irregular. The limb is constantly sort of changing direction. But I agree, sort of amplitude-wise, it's a little bit makes it a little bit challenging. But there is a kind of in this position and in this position a continuous oscillation. It's just very very high amplitude, and I guess his hands are very relaxed, so they're kind of flopping around in a way that looks a little bit confusing. So that's why I said sort of focus on the legs. It'd be odd for a patient to have two separate movement disorders in the body. And so if you look at the legs and then you go back to the arms, you can sort of see, oh, this is a postural and rest tremor. That's oscillating at a similar frequency but at a higher amplitude. So I do think it's all tremor, and we're seeing rest and posture. I'm not really seeing an action component. We haven't seen the patient sort of move from one position to the other. When he moves his legs, it looks like it abates a little bit. So mostly rest and posture. And Zachary, were you able to distinguish in your patient, was this rest, posture, action, all of the above?
All of the above.
All of the above. And was it of this similar dramatic high amplitude in your patient, or
Similar, quite dramatic, but isolated to the right side.
isolated to the right side? Yeah. Um, okay. So with that in mind, Sebastian, if this is a high amplitude rest, posture, and action tremor, what types of tremors can do that? What types of conditions can cause a tremor like that? So as Sebastian
Hmm.
said earlier, just to
So,
zoom out,
so
once you have a tremor, these are the ways you want to try to classify it, and then the more specific you can be about rest, posture, action, body parts, amplitude, frequency, the more you can zero in on the types of conditions that can cause that specific type of tremor. Yeah, go ahead, Sebastian, sorry.
yeah, no, just sorry. I mentioned cerebral tremor comes to mind as something that's very high amplitude and is can be present, at rest and also on action. That would localize to a lesion in him. Think of the left red nucleus. Um, then beyond that, cerebella certainly is high frequency, but it tends to be really exaggerated when reaching for a target. So that's sort of, but it's still possible. Uh, those are sort of my main when I see a really high amplitude. Also, I mean, psychiatric is in there. I've seen a lot of volitional tremors that are really they fluctuate a lot in amplitude, and so they might start being really exaggerated, and then you retest and it's lower. Um, so that's what comes to mind for me when I see that high amplitude tremor. And when I think about more like medium amplitude, that's when I get into the sort of Parkinson's and essential tremor, which you can separate out by the again where Parkinson's would be present at rest, and the essential tremor really is more of an action postural tremor. And then the low amplitude and often high frequency, I think more of physiological things, including kind of thyroid and enhanced physiologic anxiety and so on. So I'm leaning more towards the sort of the rubral cerebellar localization based on that appearance, but I don't know how tremors from autoimmune disease present or how a typical kind of Wilson's tremor. I imagine it's more of like a kind of a cerebellar looking tremor, but I don't know.
Yeah, great thoughts. Yeah, so if you see a tremor just at rest, in other words, the tremor is there when you're talking to the patient, and then you ask them to lift their arm, and the tremor goes away immediately. What does that make you think of, Sebastian, for just a rest tremor?
We think of Parkinson's disease,
Yeah,
idiopathic, just normal idiopathic Parkinson's disease. Yeah.
yep, yeah. Any sort of Parkinsonism, right? Whether it's Parkinson's disease or Parkinson plus syndrome or drug-induced Parkinsonism, it's usually a rest tremor, kind of relatively low frequency, kind of relatively low amplitude. And as soon as the patient takes on a posture, it usually goes away. And then once that posture becomes the new resting position, you can see what's called a reemergent tremor, where the tremor comes back, or if you distract the person on the other side, it comes back. Um, and so that's a rest tremor. And what if you see the tremor a little bit with posture and then mostly with action, but with no dysmetria? What does that make you think of?
An essential
Yeah,
tremor would come to mind. Yeah.
perfect.
And
Yeah,
and
the
you'd
essential
often see
tremor.
it also affecting other body parts like the head and the mouth is common, the neck.
That's right.
And
Yeah. So when it's no rest but posture and action, um, so a sort of higher frequency, modest amplitude can become higher amplitude over time, but no ataxia or dysmetria, that makes you think more of an essential tremor. Or most of the drug-induced and sort of metabolic tremors tend to be action tremors, higher frequency, lower amplitude, and you may see some tremulousness with posture as well. So that's kind of the least specific situation, is where you have posture and action, worse with action, high frequency, low amplitude. Even you've probably seen if you, don't get enough sleep and then drink a lot of coffee and then don't eat breakfast and then try to go for a run and you get tremulous. It's sort of action and maybe a little bit of posture. That's sort of the enhanced physiologic tremor in this category. Yeah, and then as you said, it's very rare to see a tremor that looks like Parkinson's at rest and then looks like it gets also worse with posture and action. And you mentioned rubral tremor. Have you seen a rubral tremor, Sebastian?
No, I haven't seen one in person.
Yeah, I've seen two in 3 years of residency and going on 12 years of practice now. So pretty rare. And rubral refers to the red nucleus, which is in the midbrain, right adjacent to the substantia nigra, as well as to the um, superior cerebellar peduncle or the cerebellar outflow tract. So the way I try to remember this, I don't know the exact physiology, is that if you're getting something near the substantia nigra, then you're getting some Parkinson's component to it. And if you're getting the superior cerebellar peduncle, and I believe the superior cerebellar peduncle fibers, some of them synapse in the red nucleus, so you're sort of getting like combined Parkinsonian cerebellar. Um, a cerebellar tremor you shouldn't have at rest, right? That's usually with action, and particularly action, and then it's dysmetric, meaning it's not just with action, but it worsens as you get closer to the target. Um, so if this is rest, posture, and action, that could be rubral, or as Parkinsonism gets really bad, you can see rest, posture, and action. I would imagine if essential gets bad enough, I mean, unless you're sort of perfectly still, but we're always sort of moving from one position to the next. Um, okay, and then Wilson's, good question. I mean, I've read about Wilson's, I've never seen it, and we just sort of invoked it. New movement disorder, young person, even patients I've seen very young that look like they have Parkinson's disease, and I say I got to work them up for Wilson's. They're so young. Usually they just have very early onset Parkinson's disease, in my experience. Um, so I think you can have any kind of movement disorder with Wilson's. I think you can have dystonia, tremor, all sorts of different things. Probably many different types of tremor. I don't know the specifics. And gee, for both of us, movement disorder plus liver, Sebastian and I can't peel ourselves away from Wilson's disease. I'm sure there are other conditions that can be liver and movement disorder. Um, it's hard to think of any. Without the liver, we have a new movement disorder, a new psychiatry. We'd maybe still be thinking more about something in the autoimmune encephalitis realm, which we invoked earlier on based on the chief concern. But we have to explain new liver disease in this patient. And then just saying, could some medical cause of liver disease cause this condition? Well, confusion, sure. Maybe some behavioral change, sure. But a unilateral movement disorder from a toxic metabolic condition, there are examples, but it's pretty rare. You can get focal seizures or hemichorea from hyperglycemia. Unclear why that is, um, but both are described in that context. But a unilateral movement disorder, usually think structural or, for whatever reason, Parkinson's disease and corticobasal syndrome of Parkinson's plus syndrome are usually unilateral um, and or asymmetric. But a unilateral movement disorder is a sort of a stretch for a toxic metabolic condition, except hyperglycemic hemichorea, which our colleague Gabby Pucci at University of Pittsburgh presented a case to us in the early days of Neuro VMR several years ago of a patient with hyperglycemic hemichorea with blood glucose of 400 or 500s. Okay, so we sort of worked up the movement disorder as much as we can, right? Probably it's unilateral. You'd probably get a scan and make sure there's no structural thing there, right, causing this structural lesion in the red nucleus. And if there was no liver disease here, we'd certainly be doing that. And yeah, new unilateral movement disorder, aside from an older person who clearly looks like they have Parkinson's disease, you'd probably get a scan. And certainly in a young person, you'd get a scan for any clues. But probably we'd be asking our medical colleagues to help us understand what's going on in the liver. And then we would, if we're wondering about Wilson's disease, do you know what tests you would send, Sebastian?
Yes, you'd want to do you could do serum copy. You'd want to do a urine plasmin. I'd have to jog my memory. I believe the
Yeah.
copper can be normal, but I think the urine plasmin is, maybe it goes down. I can't remember. I'd have to remember. And you
I
can
don't
also do
remember the ups and downs. Yeah,
gene testing as well.
that's right.
I think it's an ATP,
Good for
something
you.
something like that. It's going to mind. And yeah, the other thing, I mean, I'm trying to again bring together a movement disorder and liver disease. I think I'd presented a case of it when I first joined here, and it's one of the hematological diseases. Porphyria, I guess, is something, with the abdominal pain. I don't know. We're saying it's right upper quadrant. We haven't quite localized it. Acute psychiatric disturbance. I'm going to throw that in there.
Oh yeah, I remember your case of porphyria back in I think it was the first case
Mhm.
you presented.
Yeah,
And does that I know it can cause a neuropathy. Can that cause a movement disorder or I don't know?
that's where I get stuck. I mean,
Okay.
I mean, neuropathies can look like tremor if you've got a again proprioceptive loss or whatever, but that's not what we saw in the video. So, and I
Okay.
guess the other thing to ask is I don't know how the tremors in Wilson's disease, are they classically very exaggerated or subtle, and I just something I'd have to look up.
Yeah, there's this classic description of a wing beating tremor, which I think refers to
Mm-hmm.
that very high amplitude tremor brought out when the
Mm-hmm.
arms are in that sort of wing
Mm-hmm.
position. But yeah, I don't know too much about it either and
Mm-hmm.
haven't seen it live.
Mm-hmm. Would you expect it to be so unilateral? I guess that's the other thing that
I think it
confuses me
can.
about the case. Yeah.
I think it can. Yeah, but I think we're gonna find out. Yeah.
Yep.
Good. Yeah, I think the workup, yeah, is urine 24-hour copper collection and serum ceruloplasmin. The few cases where I've had young onset Parkinson's disease and thought maybe it's my first Wilson's case, I'm going to work it up. I found that those are slightly abnormal, and I get very interested. And then the liver people say, it's not, it's not that. Um, I think it has to be very abnormal, but don't quote me on that. And then you can have, the classic step one thing in the eyes, right? The Kaiser Fleischer rings. I learned recently that I actually can't see them that well without a slit lamp exam. Actually, so if you think you're just going to look in the eyes, I've looked a few times at, oh, look at that ring, and that's just arcus senilis, right? The lipid deposition, the ring around the iris. But I think to really see it, you need the ophthalmologist to do a slit lamp exam, unless the patient has very light blue eyes, and then sometimes you can see it. Per report, again, I've never seen this step. And then liver biopsy, you can, and looking at copper, I think content in the liver, and then genetic testing, good for you remembering even the gene. I don't remember that. So we'd want to get some brain imaging. We'd want to get some labs. We'd want to get some help working up the liver, probably an ultrasound, some liver function tests. But then we need help. At least I would need help interpreting them. Sebastian can probably do it. Um, and if things are pointing in the Wilson's direction, a 24-hour urine copper collection and a serum ceruloplasmin. And I think the urine copper is high and the ceruloplasmin is low because it's binding up so much copper, but I would have to look it up. Okay, Zachary, what were you and your colleagues thinking at this stage, and how did you proceed?
Very similar thoughts to you guys. Um, so some basic labs had a CBC with a normal white cell count, normal hemoglobin, but low platelet count of 90, and this was confirmed as a true thrombocytopenia. In terms of chemistry, normal urea, creat, electrolytes, and sugar. HIV test was negative. RPR test was non-reactive. Low CRP, ESR, PCT. Patient had normal thyroid functions, normal B12, B6. In terms of liver functions, had slightly raised aminotransferases. And in terms of urine, normal urine dipstick, and a drug and tox screen was negative. In terms of early imaging that we got a CT brain pre and post contrast, which was normal. The patient had an EEG, which was normal, and a lumbar puncture, which was normal, acellular, normal protein. And a
Okay.
chest X-ray, which was normal, a EKG, which was normal, and an echocardiogram, which was normal.
Okay. All we have is a low platelet so far. I think you can get that in Wilson's. I forget why. We're stuck. We're anchored. Sebastian and I have dropped
Yeah.
our anchor. Is there anything else you can even think of in your mind right now aside from Wilson's disease, Sebastian?
No, I mean, I think again, liver, dysfunctions, having liver dysfunction, you will see low platelets and abnormal INR
There.
and globulin levels. Albumin. I think I don't know if we checked that, but again, that could confirm if the albumin's low, the INR's prolonged, that there is some sort of synthetic liver dysfunction. But you mentioned the AST and ALT were only slightly elevated. Maybe I would have expected something more, exaggerated given the the level of injury. Good that we've ruled out, acute metabolic. You mentioned the urea, and that can certainly cause tremor and encephalopathy. Again, less so with like a good psychiatric rather than just general altered mental status flavor. But yeah, nothing else that's really jumping out. Did we get sometimes it reflects to getting a blood film. Maybe that might have shown us again some acanthocytes or but really yeah, I don't have much else to add at this point. I think I would would like to see an MRI, but with and without contrast again to make sure that we're not missing something in the midbrain or the cerebellum or the basal ganglia. But again, appreciate we might not have that resource available. Wonder if the Wilson's testing was sent at this stage.
Yeah, agree. It'd be helpful to have an image and make sure, there, who knows, maybe this patient has a echinococcus of the liver and an echinococcal abscess in the red nucleus. Um, and yeah, maybe the patient has endocarditis and somehow infarcted the liver. I think that would be pretty rare. I've seen the kidney, but not the liver, and infarcted the red nucleus. But yeah, we'd really be grasping at straws. But there's a unilateral something. We need a picture of the brain to make sure we're not missing anything. Do you know, Sebastian, what you can see in the brain in Wilson's disease?
Panda sign, I think it's called in the midbrain, where an actual slices it looks like a sort of face of a panda. One of our attendings is Dr. Wilson, not the namesake for the condition, but he never lets us forget the panda sign.
Ah, okay. I was going to say that's a very, very obscure finding, and I'm very impressed that you know that. Even if there's a trick to how you knew it, yeah. There's something called face of the giant panda, which something about how the midbrain and basal ganglia look. It looks like a panda face. You can Google that. There's something else. There's another. I can't remember. There's another. If you look at Radiopedia, there's uh, there's another MRI sign. I think you can see in Wilson's disease. I forget what it's called. Yeah. Um, I was reading about Wilson's recently, not because I've seen a case, but yeah, may as well let everyone here know the next continuum that's coming out next week is the Neurology of Systemic Disease Continuum, for those of you who read Continuum or have access to Continuum. And I had the good fortune to guest edit this issue and recruited a really amazing team of authors. And so there's an article on neurology of cardiac disease, neurology of renal disease, neurology of liver disease. And so I learned a lot about Wilson's from the author writing about the neurology of liver disease. If I sound like I know more about it than one would expect to know about it, not having seen a case, because all of this neurology of systemic disease is fresh in my mind. So, little plug for all the amazing authors. It's 11 articles on the neurology of systemic disease. It's going to be a great issue coming out next week. And did someone put in the chat? I know the author, one of my colleagues here at UCSF, wrote about the face of the giant panda sign, and there was something else. What is it? Oh yeah, is this it? The split thalamus? I think it was split thalamus sign. Anyway, there's all these signs. Yeah, face of the giant panda, all this kind of radiologic signs that the radiologists have these clever names for. Okay, all right. So neuroimaging, and then the copper stuff, and then if we need to, gene testing, maybe a slit lamp exam. We can't peel
Yeah,
ourselves away, Zachary. Are you going to surprise us with the first case of Wilson's we've come in proximity to, or surprise us that we've missed some very obvious
yeah,
diagnosis that we can't see because we're blinded by the bright lights reflecting off the copper of Wilson's disease?
yeah.
No, excellent thoughts. So we got an MRI of the brain which showed some T2 hyperintensities in the basal ganglia, especially the putamen, with some subtle midbrain changes. Um, and on the basis, thanks to the advances in AI, it was actually me. I was in the emergency room at the time, and I put all of this information into open evidence and asked it for possible differentials and what further testing to send. So we consulted ophthalmology to get a slit lamp exam, which showed Kaiser-Fleischer rings. And we sent off 24-hour urine copper, which was markedly elevated. So on the basis of that, we consulted our GI colleagues who agreed with us this was likely Wilson's disease. And the patient is admitted in the ward currently awaiting a liver biopsy as a final confirmatory test. But this was a case of Wilson's disease.
Amazing. You've seen one. Where are you? Sebastian and I want to come visit and see the patient if they'll consent. Where are you?
Johannesburg, South Africa.
Ah, it's a long trip, but I would consider it to see a case of Wilson's disease and learn from the patient and your colleagues. And then the treatment, Zachariah. Again, I only know a little bit about this because I was just editing this issue and reviewing this article. Is there something about the patients can sort of worsen right after the initial treatment, the sort of chelation therapy? Um,
They can worsen. They can worsen after the initial therapy. But I am told, the patient is now admitted. I'm told the patient is doing much better.
what did you use?
I
Did you
think he
use
was
zinc?
started on chelation therapy.
Yeah. Yeah, I don't remember names. Like triantine, zinc, this kind of stuff, something like that. Is that right?
I'm not familiar with the
I don't.
treatment.
I don't know either. Okay, yeah. Don't quote me on any of that stuff. Okay, great. Any other teaching points you wanted to make, Zachariah?
Um, No, not really, but it just shows that with the advances and the advent of technology, if you can pick up the important clinical signs and clinical features, and you have a useful tool like AI, you can essentially plug in the important data and it can generate quite a lot of differentials that you may not have thought of initially. And actually, Wilson's, like I said, the patient was actually worked up initially as an index psychosis patient.
Hmm.
So usually those patients don't undergo rigorous physical exams and rigorous testing, but one of our colleagues picked up the hepatomegaly, and that prompted the sending of the liver functions and the abdominal ultrasound, which confirmed hepatosplenomegaly. Um, so yeah, like I said, if you can, if you can pick up the important clinical signs and the important data, and you have a tool like AI to assist you, even though you may not have senior consultants, you can send a lot of different testing. It's like having a consultant in your pocket.
Yeah, great thoughts. Yeah, and you made the key point there that you have to give it your neurologic assessment or your medical assessment. If you put in 20 confusion, talking to self, right upper quadrant pain, you know, you might get all sorts of things. But the more specific you can be, that there's a unilateral rest action posture tremor in a patient with new liver disease, then you can get something very precise. And yeah, my mentor, who I've spoken about many times, and a mentor to many people, one of the great neurologists of the 20th and early 21st century, Marty Samuels. He used to, at a CPC, sort of conference where they'd present him the history and exam, to be provocative, he'd say, well, why do you need me as an expert? We can just Google it. And he'd show, if you Google, and I'm remembering a particular case that you can read in the um, Annals of Neurology from a few years ago. It was a case of copper deficiency myeloneuropathy, and he typed in myeloneuropathy, malnourished, zinc exposure, and the first thing that pops up is copper deficiency. And he said, "Look, it's just as good as." And he said, "Now watch this: numbness, tingling, ear pain," and typed to everything. And then Google couldn't do it, and similarly, AI would have trouble. So, as you said, helpful tool to say, I don't really have a great diagnosis for movement disorder and liver, but if I can do the medicine and figure out those are the key things I need to find out the Venn diagram for, then these tools can be um, very helpful to us. And then looking up, as you said, how do you actually work up Wilson's? Is the ceruloplasmin supposed to be low or high? And all these sorts of things that we would have to look up on UpToDate or otherwise. So, wow, thanks for bringing this case. At least I can say I know somebody who's seen a case of Wilson's disease. So I'll take that as one step removed and one step closer. So zooming out, we talked about the approach to altered mental status / psychiatric disturbance, medical, neurologic, psychiatric, and the most likely medical and the can't miss neurology. And we talked about an approach to movement disorders, in which we have to think less about localization and more about phenomenology. What is the movement? Is it tremor, chorea, Parkinsonism, tic, uh, um, myoclonus dystonia, etc.? And then once we know the movement disorder, we can divide the differential diagnosis into structural lesion, primary neurologic condition, systemic disease, or medication, drug, toxin. Great. Well, thank you, Zachariah, for bringing this amazing case and on short notice as well, presenting it beautifully and giving us a lot to talk and think about. And brilliant work as always, Sebastian, thinking through the chief concern, the history, the exam, the complex movements of that video we saw, and accompanying me in my anchoring on Wilson's. Fortunately, we anchored the ship in the right harbor here, but we could have easily been blinded by an anchoring bias here and a VMR bias. And wow, hearts are just exploding everywhere. Those are that's great to see. Okay, good. Any last questions, thoughts, reflections, teaching points? All right. Thank you very much. We will, with everyone's consent, I'll reach out to Valer, but if people are able and interested, we can certainly podcast this one. We covered a lot of ground and learned about an interesting diagnosis. Okay. Thanks, everyone. Have a great day. Have a great evening.